Good day and welcome to today's HQIC Community of Practice call. At this time, all participants are in a listen-only mode. Please note this call is being recorded. If you would like to ask a question, please enter it into the chat panel located at the bottom of your screen. During the open discussion today, you may also request to ask a verbal question by using the raise hand feature also found at the bottom of your screen. It is now my pleasure to turn the call over to Shatira Smith, CMS Facilitator. Please go ahead.
Hello, everyone. My name is Shatira Smith, and I am very excited to be here with you all today for our April Community of Practice call. Before we do get started, I do want to just reiterate a few reminders and housekeeping items. We do encourage you all to participate as you listen to the presentation today. Please be sure to submit any questions or comments that you may have via the chat box option located at the bottom of your screen. In addition to utilizing the chat feature, we will also be taking verbal questions during our open discussion session towards the end of our presentation today. The slides and recording from today's event will be shared with everyone within a week. And if we could just take a moment to have you answer the polling question that will pop up on your screen so that we may see who all we have with us today. Perfect, and we'll just give just a few more moments to close that out. Looks like the numbers are still moving, so we'll give it just a few more seconds. All right, if we could close that poll out. Okay, so it looks like we have representation from almost everyone here, but nonetheless, we are very excited that you are here to join us and welcome you to our event today. Next slide. All right, so we will start by reviewing our agenda for today. Our topic will be pressure injury prevention, zero harm. We will be hearing from Tamara Young, who is a nurse and educator from the Community Memorial Hospital. Following Tamara's presentations, there will be an open discussion, as previously mentioned, where we would love to hear from you all and engage with Tamara, with our audience to answer any questions or make any comments that you see fit. During closing remarks, we will share registration details for the next Community of Practice call and request the completion of our post-event assessment. Next slide. So as you listen to Tamara's presentation today, we do ask that you ponder on the 3 questions that are shown on your screen. Those questions are, what impactful actions can you take as a result of the information shared today? How are you able to increase engagement within your facilities to ensure a true change in patient safety? And based on what you heard today, what activities do you currently have underway that you may be able to leverage with some immediate action over the next 30, 60, or 90 days? Next slide. So it is now my pleasure to introduce our speaker for today, Tamara Young, who is a certified wound ostomy continence nurse that dedicates her career to the prevention of patient harm. She has been a registered nurse for 10 years. Tamara has spent the first 8 years providing care in the community as a home health nurse. These experiences have exposed her to incredible diversity while allowing her to deepen her understanding of unique healthcare challenges. At Community Memorial Hospital, she has fostered a successful inpatient skin and wound care program with a focus on education as the foundation of prevention. It is now my pleasure to turn the call over to Tamara. Tamara, the floor is yours.
Thank you, Shatira, for the introduction. I am deeply honored to be able to present Community Memorial Hospital's Pressure Injury Prevention Program and the commitment to enhance patient care and eliminate preventable harm to patients. I also want to thank EQIC for recognizing our accomplishments and dedication for zero harm. Next slide. Community Memorial Hospital is a 25-bed critical access hospital that serves a population of roughly 4,500 patients in 27 communities. The organization is able to meet the community's needs by providing a broad range of medical care from emergency, acute care, subacute rehab, inpatient ambulatory surgery, as well as many outpatient services. By integrating primary care, urgent care, and specialty care services under one umbrella, it facilitates a seamless transition in care and helps close gaps in the healthcare system. We are located in the town of Hamilton in central New York, nestled next to Colgate University. Next slide. Ground zero is where we started. So a gap analysis was performed, and in spring of 2023, the findings revealed an immediate need for a comprehensive pressure injury prevention program. Through this exercise, the wound ostomy continence nurse identified 3 main areas as opportunities for improvement. Next slide. Next, we zeroed in. The organization zeroed in on the 3 areas and addressed each area: people, products, and processes. For people, there was a need for skin and wound care committee. Despite the organization having a significant number of interdisciplinary committees, none were focused on skin and wound care or the prevention of. Also, there was no lead pressure injury prevention initiatives. There was a lack of interdisciplinary approach for pressure injuries. Also, it was identified there was a lack of awareness and education on pressure injury prevention. Staff self-identified as being uninformed and uneducated, and there was an all-around lack of knowledge. Next, products. There was a lack of equipment for redistribution of pressure for patients. There was a lack of standardized skincare line and formulary, and there was limited evidence-based products available. The skincare line comprised of an assortment of products in which the staff were unable to tell when to use what products. All around, there were outdated practices that were no longer considered best practice. Then we looked at processes. The pressure injury prevention policy was found to be outdated and did not encompass a range of strategies or guidelines for reducing pressure injuries, and did not include expectations of implementing interventions for pressure injury prevention. There were updates needed in the electronic medical record to facilitate ease, accuracy, and compliance for the bedside staff, and there was scarce data collection. Historically, no data had been collected or trended for quality improvement purposes on pressure injuries. Next slide. There was a huge need for culture shift in the organization. A culture shift was huge for the organization, as pressure injury prevention or wound care was never a main focus of the organization. The addition of a wound care nurse to the hospital staff was impetus for this change, but it required a culture shift to get everyone on board with the new pressure injury program. As the project lead, I fostered the culture change by being visible on the units, providing support to the frontline staff, seeing 100% of patients that were identified at risk or currently had pressure injuries, and acted as a resource for staff. It was a delicate balance when shifting culture for the staff to understand that I was sharing my expertise and was not forcing my expertise. This allowed for increased buy-in from the staff and facilitated the rollout of the program, as staff were eager to seek guidance and learn more about pressure injury prevention and treatment. With this, I focused on a preventative mindset, increasing awareness of pressure injuries throughout the facility, acknowledging the problem, and initiating that culture of safety. I was very fortunate to have a strong leadership support, which has allowed our organization to be successful with the implementation. Next slide. The Skin and Wound Care Committee. I organized the committee that would consist of an interdisciplinary team. The interdisciplinary team approach is paramount for effective pressure injury prevention because it leverages the expertise of various healthcare professionals to address the multifaceted nature of this complex issue. We met monthly and were able to start developing and implementing guidelines for pressure injury prevention, monitoring and evaluating practices, implementing quality improvement initiatives, and identifying education needs. During the meeting, we reviewed products, equipment needs, barriers to care to streamline processes, reviewed pressure injury data in all hospital-acquired pressure injuries. Review of data trends allowed for identification of education needs. Next slide. So the interdisciplinary approach is all departments. Everyone is responsible throughout our organization for pressure injury prevention. This includes the patient foremost. So each member of the team has an invaluable and irreplaceable contribution to monitoring the integrity of the patient. The team approach is critical to adoption of patient-centered care delivery. Integrating the patient and caregiver in care is crucial for promoting their active participation in their own care and improving overall outcomes. Next slide. Education was a key area that the staff and organization needed to improve pressure injury prevention. I offered a variety of education, from real-time education at the bedside to 5-minute unit huddle educations to product in-services, clinical orientation, and annual education. I learned early on that using my resources of subject matter experts and not reinventing the wheel would allow for easier implementation. I bring in third-party providers such as different reps from companies that would also reinforce that education. So using knowledge to empower the staff and focusing on the why behind the prevention was crucial. Next slide. Medline Skin Solutions is one program that CMH invested in for improvement in our pressure injury prevention program. The company provided a discovery assessment of our organization to assess our process for pressure injury prevention and wound care by using industry, clinical, and operational benchmarks. They were able to assist us and guide us in improving those areas. Based off from the discovery assessment, Medline provided standardized formulary guidelines for skin and wound care. One of the programs they offered is Skin Champions, and Skin Matters is the other. So these two programs that offer training and education that help staff function more consistent and effectively. They encourage standardization of care, and it builds practice knowledge. The Skin Champions program consists of 5 RN or LPNs. They are receiving monthly education, which will include 24 training modules on skin and wound care. And they will be an extension of the wound ostomy continence nurse. They serve as a resource for their fellow peers. The Skin Matters program is being provided for all patient care techs in our facility and is being presented during the monthly staff meeting. This includes 8 education models focused on skin care and prevention. This program will increase their knowledge and empower the staff to care for the patients with at-risk skin. Next slide. Awareness and accountability is one area that was focused on for pressure injury prevention. These posters, as you see on the screen, are hung throughout our organization at each department. This includes our security and nutrition in all those departments that don't always have a direct bedside factor. So having the entire organization aware and accountable allows us to be more responsible and have everyone in tune to that zero harm aspect. Also, having these signs visible allows for visitors and patients to see that we are dedicated to that no harm across the board. During the leadership safety meeting in the morning, we also have this awareness. We announced the last pressure injury date and the number of days since the last pressure injury. And when a pressure injury does occur, we discuss during that time the pressure injury and any areas that we need to improve on. Next slide. Next, we zeroed out, really focusing on the best practice 6 basic components of pressure injury prevention, which includes the skin inspection, risk assessment, pressure redistribution and offloading, maintaining skin health, nutrition and hydration, patient and family education. Pressure injury prevention based on knowledge and assessment data related to the clinical conditions. So really looking at those patients as a whole, their comorbidities, their current state of health, overall risk for pressure injuries, and also looking at resources availability, such as people and environment. Next slide. A comprehensive skin assessment is one area of focus. The comprehensive skin assessment is completed on admission every shift, transfers between units, and change in patient's condition. This includes a head-to-toe assessment looking for any existing pressure injuries or skin impairments, and with removing all dressings from the patient unless contraindicated. Also assessing under medical devices, which includes indwelling catheters, oxygen, any external medical devices that could potentially cause skin damage for our patients. Having this assessment establishes that baseline and effectiveness of treatment. Also during assessment, the wound care nurse is consulted for any pressure injuries or concerning areas, even looking at areas that are red that the nurse may not know if it is truly a potential pressure injury. Next slide. At CMH, we use the standardized and validated Braden scale, which assists with identifying patients that are at risk for pressure injuries and guides pressure injury prevention interventions. It is completed again on admission every shift, transferred between the units, and when the patient's condition changes. Intervention should focus on the Braden subscales that are specifically putting that patient at risk. Physiologically, a pressure injury can develop in as early as 1 hour. So early identification is important for prevention. Encouraging the staff to early identify and implement the interventions prior to the wound care nurse seeing that patient is crucial in that prevention measures. Also, having the team communicate to each other for that patient's at-risk status and interventions that are important for that patient. So including those patient care techs that are at that bedside at all hours and during a shift handoff. Also, the patient's plan of care board that is located in the room, we use this for communication of those interventions. When the patient gets devices such as low air loss pumps, we put that on the board so that that patient, the family, the nurses, the whole team as a whole is able to understand these are the interventions that are important for these patients. Next slide. The Braden Scale Intervention Table, as you see on the screen, is one initiative that assists a nurse with implementation of pressure injury interventions. This provides a guide that is individualized to patients based off the risk areas. So this is provided during orientation, and I also provide it again throughout the year, reinforcing it. I also have a board, an education board that it hangs on. So it really allows that nurse to have a standardized guide of when to implement one interventions while also making it individualized for that patient. Next slide. Shambles is another initiative for pressure injury prevention. It is hung outside patients' rooms, on medication carts, on education reference boards throughout the facility, and also on the nurses' badges. It is a reminder to check these areas: sacrum, heels, appliances, moistures, bony prominences, layers, edema, and sweep the bed for trash during your purposeful rounding. Next slide. Prophylactic dressings are applied over intact skin that are considered high-risk areas. It assists with reducing friction, shear, moisture, pressure injuries. The nurse is to peel the dressing back every shift for inspection of those areas. Patients that have a Braden of less than 14, which means they are at moderate risk for pressure injuries, should have a sacral dressing applied, even if that skin shows no concerns currently. Use of these prophylactic dressings should be used in conjunction with other interventions instead of replacing them. Next slide. These are two initiatives that were implemented at our facility. We call them links, which is what I need to know. So these are very quick flyers that are very focused on topics that allows that bedside nurse to get quick education for implementation for their daily care. On the left side is one that I had created when I first came to the facility, finding a walk note in the EMR. So it guides the staff where to find my notes, what I document on, and it also drives or assists that nurse with what should the wound care nurse be called for. Also, I always love when in doubt, walk it out. So if the nurses have any concerns, don't know what they're looking at, don't know what to do, always contact me, as I am a guided resource for them. On the right side is another skin wink. So this was on sacral pressure injury prevention dressing. So this is when we first rolled out that prophylactic dressing, really focusing on that prevention of harm. So having those patients have that sacral dressing for that Braden scale of 14 or less, changing it. It doesn't have to be changed as frequently. So every 3 to 7 days, really having the date initials, if it's a treatment or prevention, so that next nurse knows, am I peeling that back that shift or not? Mepilex is one product that we use. They have done studies that show prophylactic dressings really help prevent those injuries. Next slide. Equipment for pressure redistribution. So prior to development of the program, the facility had minimal to no pressure redistribution surfaces or devices. I had asked at one point early on in my journey for a mattress or a pump that would provide support for the redistribution of pressure. And the person looked at me like I had two heads. Then I had asked another person, which said, I think we have this purple mattress somewhere, maybe in storage. When I finally was able to get the mattress out and on the patient's bed, the equipment did not work. Since rolling out the program, I have been able to successfully get Stryker low air loss pumps for pressure redistribution and moisture management for our facility. As of today, I have been able to order 8 pumps. Also, we have been able to improve patient safety by purchasing and use of safe patient handling equipment, such as hover mats and hover jacks. Also, we had limited Roho cushions available, which helps with the patients when they're out of bed and up in the chairs or wheelchairs. So we now have 7 of those for patient use. This is significant for our facility as it has contributed to decrease in not only our pressure injuries, but has decreased our shear, moisture, and friction-related skin injuries. Next slide. Another tool that I was able to create is the support surface algorithm. So as you see on the screen, it guides the staff to understanding when to use the low air loss pumps. So if the patient is at risk based off of the Braden scale, has increased moisture issues, current skin impairment, and just plain clinical judgment, the nurse is able to, without even an order, applying this pressure injury prevention device. Also, it's good for patients that have morbid obesity. A lot of patients with morbid obesity tend to have more moisture, even in areas. So using that pump to have that airflow decreases those moisture concerns. Next slide. This is one formulary that we were able to create with that Medline Skin Solutions program. So the Medline Remedy Skincare Guidelines is a standardized skincare line that guides the staff on when to use what products. This also assists with cost efficiency with improvement patient outcomes. Many times I have went into patients' room and they have a variety of different products in the room. A lot of the times I feel the nurses didn't understand when exactly to use what products. So having this color-coded line as well as this color-coded guide to guide the staff, not only the nurses, but those bedside aides, really drive that care and improve those patient outcomes. Next slide. Nutrition status is very important for those patients that are at risk for pressure injuries. Hospitalized patients are at great risk for undernutrition. So having a nutrition screen completed on admission and as needed with patient change of status is important for these patients to be identified early. When a patient is identified at risk for nutrition, there is an order that is automatically placed off of that admission assessment. The admission assessment looks at poor intake, tube feeding, TPN, weight loss without trying, malnutrition, also pressure injuries that are present on admission. So again, the system will automatically put in that nutrition consult for that nutritionist to see them. The nutrition consult is for patients at risk or current impairment. The dietitian or the nutritionist at our facility sees every patient within 24 to 48 hours of admission. So having that consult just puts that patient at a higher priority to have that nutritionist go in to see them sooner. Also monitoring weights, adequacy of oral intake, enteral, parental intake. Also, the nutrition staff looks at, does that patient need maybe a supplemental nutrition, such as Ensure, Juven, or Magic Cups? The bedside staff also assist patients with feeding and encourage increased intake. So some of our patients might not be able to cut up their meals or even be able to feed themselves. So really focusing on having our staff be able to be at their bedside and assisting with those feedings. The wound nurse and the dietitian collaborate very frequently, especially on patients that are high risk or already have a skin impairment. Next slide. The plan of care is important for these patients that not only have a skin impairment, but also are at risk for those skin integrity impairments. So really looking at an individualized care plan to address the patient's at-risk needs. Also having an action plan of how to address those areas at need. Prioritizing and addressing those areas, collaborating with the patient and family to set obtainable goals, patient and family education on pressure injury prevention and management, and also empowering that patient and family to advocate for themselves as well. Next slide. Leading the way to zero. We have been able to do this by ensuring the leadership is committed, adopting a safety culture, incorporating processes into improvement tools and methodologies, demonstrating accountability for safety and quality throughout the entire organization. Next slide. So next we focused on that updating policies and procedures to guide the program. So Lippincott is another way that our facility has invested in evidence-based practice as well as best practice. Lippincott provides skin and wound care procedures that guides the staff on prevention and treatment of skin trauma and pressure injuries. We have updated the procedures to be facility specific. The software is easily accessible by being located on every computer desktop and does not require a login. Next slide. Electronic medical record updates were identified as being needed. So the key to maintaining pressure injury prevention program is accurate and consistent documentation that accurately reflects the care that's being provided. I found that there were many areas in our EMR that were missing or did not allow the bedside staff to accurately document the patient's status or care. The EMR was updated to ensure thorough and user-friendly documentation for pressure injury prevention, such as making the Braden scale mandatory at those intervals previously discussed, and having supportive pressure injury interventions. Due to our organization being partnered with Cross Hospital and using the same EMR, the Braden interventions were actually not facility specific. There was equipment and brands of products that were not used in our facility, so the staff were not able to accurately document the interventions that they were being performed. Also, adding in patient education for pressure injury prevention and pressure injuries. This being added to the system allows that nurse to take ownership and also show that they are providing this education. If they would have had to free text that documentation in order to provide it in the EMR. So to increase accuracy of data collection, I was able to have our EMR build a report that emails me daily on any patients that have a new documented pressure injury and or change in stage or location of pressure injuries. Most recently, I was able to get a wound ostomy consult in our EMR. Prior to this, I would have to only have communication verbally with the bedside staff as well as the providers. So now the providers are able to put a consult in the system as well as continuing that face-to-face consultations for any patients that are at risk for pressure injuries or current concerns. Really being able to close that gap of care and ensure our patients are getting the best care. Next slide. Quality chart audits was crucial for our organization. I audit, even to this day, patients' charts daily for current skin injuries, reviewing the Braden scale score, appropriate interventions for the patients, and supporting skin integrity plan of cares. I then, in real time, am able to provide the frontline staff with education and early identification and implementation of the interventions of patients that are at risk for pressure injuries. As many of you know, those bedside nurses, they have a million things going on. So having that continuous reinforcement allows them to have that extra eye, as well as making sure our patients are being identified early and getting those interventions implemented. Next slide. For any hospital-acquired pressure injuries, I conduct a root cause analysis. It is used as a learning and growing opportunity for the organization. When a hospital-acquired pressure injury does occur, the staff and I complete a post-pressure injury huddle at bedside at the time that the incident is identified. This allows for real in-time evaluation of the incident and to provide education in real time. The same day of the incident, I then do a chart review for that root cause analysis and provide education on the findings and areas for opportunity for improvement to that unit. And then each day for 1 week, the incident is reviewed with the staff on each shift. This allows to tell the patient story, really focusing on that patient story, lets those nurses know, like, this is a real injury to a patient that most likely probably shouldn't have occurred. So having that real feeling for those nurses makes it memorable for them to maybe next time putting up that patient's heels or repositioning those patients. This allows for awareness of patient harm and accountability for the organization and the team as a whole. The incident, again, is reviewed at that leadership safety meeting the following morning. The RCA allows for tracking of trends and also identifying areas of improvement. Next slide. With any pressure injury prevention program, one must continuously evaluate and reevaluate the process to ensure staying up to date on evidence-based practice and to maintaining sustainability. One way our organization did this by performing a rapid cycle improvement process with EQIC. The rapid cycle improvement identified areas of improvement and since then has been able to implement these areas that they recommended for updating, such as the pressure injury prevention policy, clinical orientation, facility-wide pressure injury awareness. Next slide. Zero to hero. Although we aren't perfect, I would definitely say we are on the track to getting to that zero mark. By fostering a culture that values prevention, educates staff and patients, encourages collaboration, and uses data to drive improvement, Community Memorial Hospital has significantly reduced the incidences of pressure injuries. The pressure injury prevalence rate has been maintained at 0. The incident rate has declined by 50% since implementation. Notably, CMH did not have a pressure injury from September 9th, 2023 to February 2nd, 2024. Prevalence studies are a snapshot of pressure injuries burden in our facility at a significant time. That includes stage 2 or graders. At the beginning, I was doing a quarterly prevalence study. And then because we maintained that 0, I increased it to monthly to make sure that we are capturing any pressure injuries accurately. Also, this allows for real-time education and recommendations for pressure injury prevention interventions. Also, during this time, review of prevalence study findings with the staff to make sure that they are aware, again, of any pressure injuries. Although prevalence studies are the most common reported data as an industry, I do not feel that they depict a true picture of an organization's pressure injury state. As seen with our data, we have had 0 pressure injuries on a prevalence study date, but we in fact have had pressure injuries as an organization. The incidence rates are all new pressure injuries that develop after admission to med-surg SCU specifically that are stage 2 or greater. Because incidence rates are ongoing monitoring and surveillance, they are considered more reflective of the quality care of the setting. The gold standard for evaluating pressure injury prevention efforts involves a combination of approaches, including prevalence studies, incidence studies, and quality improvement initiatives. Next slide. Performance improvement. As of 2024, the wound ostomy is now an official department at Community Memorial Hospital. The wound nurse collects and presents quality data through the performance improvement program to continue to improve patient quality of care and patient outcomes. The team is able to maintain the pressure injury prevention program by continuously evaluating the process, staying up to date with best practices, ongoing staff training, and data collection and analysis. Next slide. So quality is not an act, it's an habit. So this means that quality is everything. There's no other alternative to it. Quality is the act of doing something in a continuous manner, and ultimately it's a habit that leads to excellence. Therefore, every decision we make needs to start with our discretion, and we need to ask ourselves if it's the decision is of the highest quality. Once we practice it, it'll become a habit, and eventually everything we do will become the highest quality. Next slide. So references that I've included, I feel are very important as they are evidence-based practice that has led creation of our program. And this also drives those patient outcomes and patient safety. Thank you so much. Thank you again for allowing me to present today. We will turn the call back over to Shatira.
Perfect. Thanks so much. So I do just want to give another thank you to Tamara for giving us such a wonderful presentation. If we could go ahead to the next slide. On your screen, you will see the same 3 questions that we showed you at the top of the call. These are the questions that we did ask you to ponder on as you listened to Tamara's presentation today. Those questions are, what impactful actions can you take as a result of the information shared today? How are you able to increase engagement within your facilities to ensure a true change in patient safety? And based on what you heard today, what activities do you currently have underway that can leverage immediate action over the next 30, 60, or 90 days? So as promised, we have landed at our open discussion portion of today's call, where we would love to hear from you all. Any questions or comments that you may have, feel free to plug them into the chat box. And you may also speak verbally by using our phone lines. If we could just remind our audience on how they may speak verbally.
At the bottom of your screen, there is a raise hand feature. So if you click that, you can do that, or you can click in participants and find the raise hand feature there.
Perfect. Thank you. So before we get started, I will just check with you to see if we had anyone that is requesting to speak verbally.
Somebody did raise their hand and then turned it right back off. So I think no raised hands at this time.
Okay, sounds good. I did also see that raised hand. And it doesn't look like we have any comments in the chat box just yet. We do have a lot of praises for you, Tamara. It looks like our audience really enjoyed your presentation today. Seeing a lot of thank yous in the chat box. So I just wanted to be able to share that with you because that is also exciting. Now we have one question that came in. This question came in from Priscilla. Her question reads, can we have the copy of the gap analysis that you did? So Priscilla, we do share pieces of the presentation within the week's time. So that if that is something that Tamara would love to share with the audience, we can facilitate that to get it out to everyone. Tamara, we can talk about that behind the scenes if you're unsure. All right, so Tamara, we have another question for you. That question reads, you have talked about the nurses and nursing assistants education. Can you tell us what are you doing to educate your providers on pressure injuries?
Yes, thank you so much. So it's been a challenge to be able to get the providers engaged. I am still currently in the process of still getting them engaged. I try to, whenever possible, if they are on the units, when I am getting them to that bedside, doing that bedside education. But really trying to get them to attend the in-services. I've been trying to think of creative ways. Recently, I had spoke with our operating room manager about having some outside resources come in and sit maybe 4 hours in our ambulatory section. And then as those providers come out the OR, have lunch quickly and get even a 5-minute education. So I'm still continuing to try to work on ways to strategically get them engaged because they are very busy individuals. So getting them together is not been a success for me.
Thank you, Tamara, and thank you for your transparency as well. We all know that that can be a heavy lift. All right, so we have another question. This question came in from Shelley. That question reads, were there ways that you needed to overcome challenges with engagement with staff, helping them to identify importance of the issues contributing to facility-acquired pressure injuries?
So yes, there was definitely challenges. Challenges just having this new wound care nurse. We are a very small rural hospital. So a lot of the people in the organization have been here 20 to 40 years even. So really having them see that there was problems, I guess you would say, because basically that patient harm. So really making them feel like I was a resource, really listening, not overriding what they were doing, but providing that insight. Really getting them to understand that I'm a resource. I am someone that's going to help them, making sure that their patients are safe. Because at the end of the day, that's the goal of everyone, is that patient being safe and getting the best care. So really kind of weaseling my way into their hearts, if you would say. Once they saw, really doing those root cause analysis at bedside and after those incidences, really having them understand the importance of why we need to focus on these areas to prevent those future harms.
Perfect. That sounds amazing. I know here on my side, I also have some personal notes. You talked a lot about some of the tools that you offer, some of the programs, the shambles, the support surface selection tool, the intervention table. So it looks like you are providing a lot of resources as well to kind of keep that reinforcement and consistency going. So that sounds great. All right, so we're going to go on to the next question. That question is from Priscilla, and it reads, did you also do a fish, my screen is moving faster than I can read. Let me start that over. Did you also do a fishbone analysis to identify the gaps in the pressure injury prevention program?
I did not. So really doing the gaps, when I started the program, I started at the HQR foundations that guides pressure injury prevention programs. Also using a tool that's actually on the EQIC website for looking at those incidences, looking at all those areas that are really those 6 basic best practices and building off from that for that pressure injury prevention program.
All right. Another question from Priscilla. She says, we currently don't have a wound care nurse. The process now is that when a wound consult is entered, providers are supposed to assess the wound, stage and order treatments. Any insight on how we can have providers engaged in this process?
I would say the providers are at a struggle themselves. It is not part of their curriculum, even in doctorate school, to be able to assess wounds and really understand those basics. So they probably aren't engaging most of the time is because they don't know. Most of the times they just truly don't know what's going on. They aren't very well even at staging, even recommendations on wound care, I find. So I would say trying to get, if your education department, trying to get them to get education to those providers. I always recommend, if your facility will allow, getting a nurse that's really interested in the wound care and getting them to a program. There's some programs that's very short. The wound care certifications are a shorter program. The wound ostomy incontinence nurse, I'm kind of biased, but I love their program as a whole. So it's 2 different aspects, I would say, looking at education, which will allow them to get engaged for those providers. And then again, trying to get a wound care nurse, even if it's a bedside nurse that the facility is willing to send them for education, that would be beneficial.
Great. Thank you so much for that answer. I am just going to check in to see if we have anyone that is requesting to speak verbally before we close out today.
No raised hands, but if you would like to ask a verbal question, okay, we have Priscilla Ibone.
Okay, the floor is yours.
Go ahead and unmute,
Thank you.
please.
Yeah, thank you so much for the suggestion about getting a bedside nurse.
It looks like Priscilla has been muted.
Program that we can get someone to go do.
So Priscilla, you cut out a bit. We missed the first portion of the question. So if you could repeat your question for the audience. Priscilla, are you with us?
Yeah. Can you hear me?
Okay. Yes, we can hear you much better. So go ahead and repeat your question for us.
No, what I was saying is that thank you so much for the suggestion to get the bedside nurse to do the wound certification. Is there any particular wound certification program you may recommend?
So it's going to depend on the nurse. So there is multiple different certifications. If you have a bachelor's degree, as I said, I'm biased to the Wound Ostomy Incontinence Nurse Society. So you have to have a bachelor's degree for that. It's a longer program. But the wound care certification, and it's also the wound care certification's a little bit cheaper as well. But really, any program you can even search, even Google it, see what programs are out there. Any of them that you find are going to be adequate to provide that basic knowledge that will guide them to be able to provide that.
Okay, thank you.
Thank you, Priscilla. Thank you, Tamara. All right, so that's going to wrap our Q&A open discussion portion of today's call. I do thank you all for engaging with Tamara and asking those important questions and making some great comments. If we could go ahead to the next slide. Okay, perfect. If we could launch our 2 closing polling questions. So if you guys could just take a second to answer the 2 questions on your screen, that would be very helpful. And we'll give about 1 minute for the audience to complete this poll.
And Shatira, while they are doing that poll, Nina had her hand raised.
Okay, let's multitask here. So Nina, if you want to go ahead and come off of mute and make your question, Tamara has been providing some wonderful answers, so hopefully we can get something for you.
Hi, are you able to hear me?
Yes,
Yes.
we hear you perfectly.
Tamara, thank you for that great presentation. I just wanted to make a comment regarding the question about having providers assess the wound and stage. Pressure injury is one of the few documentation that coders can use from the RN. So if you have your RN, she can measure and stage the wound, but your PCP has to be in agreement with that staging, and that coder can use that documentation. I don't believe the idea is for PCPs or whoever that attending physician is to go ahead and measure and stage those wounds.
Correct.
Coders can
Yes.
use that information.
And part of my program that I didn't mention is basically if I do identify a pressure injury, I stage it, I measure it, and then I go back to that provider and provide that education. And then I make sure that they document it in their note. And I go back even the next day to recheck and ensure that they document it in those notes. Because also I wouldn't want a pressure injury to become a hospital-acquired pressure injury when it really came from that outside, that community.
Right. Totally agree.
All right, that sounds
Thank you.
great. All right, thanks, guys. So thank you for that question. Thank you for that answer. And also thank you guys for completing the poll questions as well. If we could go ahead to the next slide. All right, so as promised, we are inviting you all to join us for our next Community of Practice call, which will be held on Thursday, May 9th from 1 to 2 p.m. Eastern Time. We would like to invite you to register for this call. We will be sharing the registration link within the chat box for your reference as well. Next slide. And we have arrived at the end of our presentation for today. We thank you again for your participation in today's Community of Practice call. We hope you found some value in the topics discussed and heard some great suggestions and strategies that you may take back with you. As a reminder, we do ask that you please complete the post-event assessment upon exiting the webinar today. The assessment will automatically pop up in your browser and should take approximately 4 minutes to complete. We value your feedback, which will help guide the content for future HQIC events. This concludes today's event. Thank you for joining.
That does conclude today's session. You may now disconnect.